Okay, good afternoon, ladies and gentlemen. Welcome to our IC checkpoints for glaucoma diagnosis in a busy OPD. Today, ophthalmologists are seeing more and more patients, and as a result, they're often quite pressed for time. In this situation, there is a tendency to miss the diagnosis of glaucoma, which may be lurking. Now, this is an unfortunate situation because at present, there is no screening programs for glaucoma. The onus of diagnosing glaucoma rests within each and every individual ophthalmologist, irrespective of his specialty, irrespective of where and how he practices. So this IC is going to offer certain key points by which you can identify glaucoma. It's going to give you a checklist of key clinical findings by which you can detect any coexisting glaucoma, and you can make a glaucoma evaluation a part of your comprehensive eye examination. Now we have a group of very experienced glaucoma experts in my panel today. And before they come, I will start. I will be talking about the clinical red flags that you may find during your examination, which will help you identify the presence of glaucoma. Now, glaucoma is not an uncommon disease. In fact, 1/5 of the global burden of glaucoma is within India. Studies have shown that 1 in 8 people above the age of 40 is either suffering from glaucoma or is at a risk of the disease. Now, screening for glaucoma is not feasible, as I've said before. So opportunistic screening of persons over 40 years who attend the IOPD is recommended. Now, certain types of glaucoma present with obvious signs and symptoms. So when you have an acute form of primary angle closure glaucoma, or you have some of the secondary glaucomas, they have obvious presenting features, and the diagnosis is quite obvious. However, most types of glaucomas are silent. This includes the open angle glaucoma, most forms of primary angle closure glaucoma, and the common types of secondary glaucomas, such as the pseudo-exfoliative glaucomas and the steroid glaucomas. I will be focusing on this group of glaucomas mostly. Now, population-based studies and clinical trials have identified certain individuals who are at a greater risk of developing glaucoma. Of these, patients who are over 40 years of age and those individuals who have been found to have an intraocular pressure greater than 21 millimeters of mercury, these are the two groups of patients who are at a greater risk. Other risk factors are family history of glaucoma, those patients who have used steroids, pseudo-exfoliation, the presence of myopia or shallow AC. These are very significant risk factors. And another risk factor is, of course, diabetes mellitus. A host of risk factors have been found, but their association is not as strong as the ones I have just mentioned. A comprehensive patient history will then help us identify which one of these patients are at a greater risk of developing glaucoma. When we see an older patient, we have a tendency to think, well, this patient may have cataract, but this patient may also have glaucoma. There is a significant risk of open angle glaucoma after the age of 60 years, and the risk increases with each subsequent decade of life. Family members who have suffered from glaucoma also have the first-degree relatives of glaucoma patients also have a greater risk of developing glaucoma. We always take a complete medical history. It is our norm. In a busy OPD, it may not always be possible. But if you have to ask for one drug, then ask for the use of steroids. Elevation of intraocular pressure is seen in 18 to 30%, 36% of the population, irrespective of which whichever route of administration. And this is even more important now when the use of steroid has increased in the pandemic for treating the complications of COVID. A medical history is very significant. In the past, there was some confusion whether diabetes are at a greater risk of, or not, but recent meta-analysis have shown that diabetes mellitus is a significant risk factor. If a patient has arthritis, he might have used steroids, or he might be at a he might have uveitis, which can be associated with secondary glaucoma. And always we must ask whether the patient has had eye injury or an eye operation in the past, because these patients are at a greater risk of developing secondary glaucomas. The refractive status is also very important. Myopes have shown to have a 2 to 5 times higher prevalence of primary open-angle glaucoma. The association is greater for higher degrees of myopia, but is present for myopia as low as -1 diopter. Hyperopes per se are not has not been as identified as a risk factor, but hyperopic eyes do have shallow anterior chamber, and shallow anterior chamber has been identified as a risk factor for primary angle closure glaucoma. Now, coming to the slit lamp examination, this is important for 2 reasons. One is to detect the signs of angle closure glaucoma, and the second is to detect the presence of any secondary glaucoma. Now, when it's an acute attack of angle closure, the signs and symptoms are often quite obvious. But a chronic angle closure disease often has very subtle features, but usually most of them will have a shallow anterior chamber. So we must try to detect a shallow anterior chamber. When we are using the torch to examine the pupils, we can also look for the anterior chamber depth by the pen torch method, which is perhaps not the best method, but it is not totally useless. At the slit lamp, the Van Herrick's test is also quite useful. It has a sensitivity of 61.9% and a specificity of 89.3%. It is not, however, a replacement for gonioscopy. In 1996, Dr. Thomas and co-workers remarked, ideally, every patient attending an ophthalmology clinic should undergo a gonioscopic evaluation. In a busy outpatient clinic, this ideal is impractical. So Van Herrick's test is a quick method of estimating the depth of the anterior chamber. Now, it utilizes a slit lamp beam to compare the thickness of the cornea to the depth of the peripheral anterior chamber. Now, we all know how to do this. It's a very simple test. We keep the observation B column of the slit lamp in the central position, and we put the illumination system at 60 degrees. We make the illumination slit very narrow, and we make it as bright as possible, and we shine the illumination beam onto the peripheral cornea. We will get 2 slits. One is the bright corneal slit, and then we will get an optically darker slit between the cornea and the iris. And we we compare the thickness of the peripheral anterior depth to that of the corneal slit. Van Herrick then graded the peripheral anterior chamber depth according to how the thickness was in relation to the corneal thickness. Now, if the peripheral anterior chamber depth is equal to the corneal thickness, if the peripheral anterior chamber depth is between half to full 1 thickness, or if it is between 1/4 to even full thickness of the cornea, then we don't have to worry. These are grades 2, 3, and 4. But if the cornea is 1/4 to even less, then we are worried, and a gonioscopy is must to identify any angle and narrow angles. Secondary glaucomas constitute 22% of all glaucomas. So it's very important to do a slit lamp examination, and often we have clues which will indicate the etiology of the glaucoma. Pseudoexfoliative glaucoma, neovascular glaucoma, steroid-induced glaucoma, inflammatory glaucoma. These are the commoner forms of glaucoma. And a quick examination, looking at the pupil, looking at the conjunctiva, cornea, the iris, and the lens in a systematic manner will always identify the presence of the secondary glaucoma. It is important to do this slit lamp both in the dilated and in the undilated condition, especially because certain features may become very much more obvious. In a pseudoexfoliative glaucoma, if you dilate it, you will see the classical bullseye pattern of fibrillar deposits on the anterior capsule, and this might not be so obvious if it's not dilated. High intraocular pressure is a significant risk factor for all glaucomas and is the only modifiable one. It is so important to do a proper applanation tonometry. 21 millimeters is often cited as the upper border of normal. Dr. Manadik Singh will then now share his experiences on intraocular pressure after this talk. Gonioscopy is the current gold standard for evaluating primary angle closure disease. In India, the incidence of primary angle closure is as high and form half of all adult primary glaucomas. Gonioscopy is also important for detecting many other diseases, such as pseudoexfoliative glaucoma. The disc and the retinal nerve fiber evaluation forms a cornerstone of the examination, and Dr. Pal will be speaking on this subsequently. So here is my checklist, which you can do in part of all of your comprehensive examinations so that you don't miss out. When you see a patient, if he is over 60, if he has diabetes, if he has myopia, be aware that these patients are at risk for glaucoma. Make it a point of asking every patient whether he has a family history of glaucoma, whether he has used steroid or is suffering from any diseases in which he may be using steroids, or whether he has an injury or a prior eye operation. Please check for the presence of delicate apparent fibrillary defect. Please check for the anterior chamber depth. Please check for pseudoexfoliation and rubeosis. Make intraocular examination, gonioscopy, and disc evaluation an integral part of all of your eye examination, and confirm by visual field analysis and imaging of the disc and retina. Thank you.